Good morning, everyone. We are in very strange times, in fact, in very weird times. Never before in my lifetime has there been such a tremendous assault on your privacy or freedom of speech on a global scale. I, of course, am talking about the pandemic, the response of various countries to the pandemic has been quite strange. In fact, very bewildering, bearing in mind that we all know and we are quite aware that the virus was made in Wuhan in China. The research or the technology was provided by the Americans. The Wuhan lab was funded by the Americans, in fact, by the American Defense Forces, the defense establishment. And it is still a moot point whether the virus accidentally spilled out or whether it was deliberately released. We don't know that. It's unimportant. But the fact is that the waves keep coming. And we were told in the beginning that there was absolutely no treatment. The best choice you had was to stay home and wait for the vaccines to be developed. The vaccines did come. They came, and the vaccination program began in December 2020. And by 2021, a large percentage of the populations in the advanced countries, in the rich countries, had been vaccinated. And then, of course, it was repeatedly said that the vaccine was safe and effective. However, people did come to notice that there were some strange things happening, such as some very unusual deaths were taking place. And by 2022, these murmurs had increased. And now we have some sort of data on these so-called strange deaths, or what is now technically called excess deaths. This book is very nice. It's a very new book. It's a very small book available on Amazon. I would urge you to go through it because it has a lot of references. On the first page, of course, we get informed that the chief of the fact checkers group in Reuters is also in the board of directors of Pfizer company. So here, of course, we have a huge conflict of interest. I'll repeat that. The book informs us that the chairman, or the person who founded the fact checkers for Reuters, is also at the same time a member of board of the Pfizer company, which is making the messenger RNA vaccine. The book is about these sudden deaths, the excess deaths, and it attempts to understand why these deaths are occurring. And they take this data from the Society of Actuaries in America, and you all can access this this website, the Society of Actuaries in the US. They have published this data in August 2022. It is on the internet. It is freely available, and I will provide a link to this. Right now, I am showing you a slide wherein they are talking about causes of death which have occurred in the recent past. And here we have the various quarters of different years, starting from 2020, 2021, and the first quarter of 2022. What is remarkable is that there are deaths because of COVID. They remain almost the same throughout these 2 years. But the red stuff, the red color on the various bars, is deaths because of unknown causes. This suddenly shows a striking increase in the first quarter of 2022. We don't have data after that, but what is clearly seen is that unknown deaths have increased in the first quarter of 2022. The dark blue lines, the dark blue graphs are because of deaths because of other diseases. Obviously, this must be heart disease, cancer, diabetes, strokes, etc., etc., etc. There is further granular stratification by the actuarial group of the US, and they tell us the deaths in the different age groups. And what is striking is the third quarter of 2021. What we find here is that they have given us the excess mortality now. The previous graph was just deaths. Now we have excess mortality as compared to the previous average of 5 years. And this is divided into the age brackets from 0 to 44, from 44 to 64, and 65 and above. What is shown here in the red highlight is that in the third quarter of 2021, there is almost an 80% increase in excess deaths in people till 44 years. And in people between 44 and 65 years, there is a 62% excess death. Now, this is important because it is here, that is from July to September of 2021, when the US government came down very strongly with their vaccine mandates. President Biden went public and insisted that everyone took the vaccines. And we further subdivide these age groups. And once again, we look at the different years, but we look very closely into the third quarter of 2021. We have now further subdivision as per age. We have 15 to 25, 25 to 45, and 45 to 55. And we find, lo and behold, an excess death to the tune of 78%, 100%, and 80%. Now, these are big figures that excess deaths increased again in the third quarter of 2021. And on an average, there was an increase of 34% in excess deaths. Now, the question is, what is causing, or what are the various causes of these excess deaths? The previous slides were the American data. Now, this slide is telling us the data from the United Kingdom, from England, from the Office of the National Statistics. And once again, we can clearly see that in adults, that is above the age of 15 years, after vaccination began, we find that the graph of excess deaths begins to increase. The red graph, the red line is of children below the age of 14 years, 14 or below. And we see initially that there was a fall in excess deaths. There was a decline in excess deaths in the beginning of the pandemic, most probably because, number one, children are not affected by COVID-19. And secondly, these were the times when children were under house arrest. They were not in school, they were not playing around, they were in their homes. So therefore, the causes of death in children, which usually are accidents or some sort of injury, were not occurring. And therefore, there was a slight decline in the deaths in children. However, once the children were vaccinated, we find that even in them, the graph, the line for the excess deaths begins to increase. And here we have data again from the Office of National Statistics. And we can see clearly that in 2022, up to the 27th week, that means we're talking of almost 5 months, we clearly see that in all age groups, there is a steady increase in excess deaths. Now here we will have to pause, because I do not want to indulge myself by saying that all these excess deaths are because of vaccine effects. Now, the important thing here is that these excess deaths in England were following their vaccination program. That is very important to keep in mind, that the excess deaths have come in after the vaccination program, and they were not there before that. Now, that undoubtedly is true, that there is some association between excess deaths and vaccination. However, this is very important to bear in mind, that every death you hear about or you read about or what people tell you, every death is not because of a vaccine adverse effect. And we must keep in mind that in India, the messenger RNA vaccines were not employed. Now, to underline my point, this is a case report which is published in a very good journal, Heart Rhythm Case Reports. This was published in May 2020. The timing is important. This was published in May 2020. This describes a 49-year-old man who has a vaccination for hepatitis B. Following that, he is slightly feverish, and then he collapses for 1 or 2 minutes. Right? There is a 49-year-old man. In fact, this man is a Bangladeshi. And following a hepatitis vaccine shot, the second shot, within 48 hours, this man collapses for 1 or 2 minutes. He is brought to the hospital, and this is the initial ECG. What is clearly seen here is that in V1 and V2, there is a slight elevation of the ST segment. So the clinicians or the treating doctors suspected that the man is having an acute anterior infarction. So therefore, he had an angiography done, which showed that the coronary arteries were normal. An echo was done. The echo again was normal. But that evening, this man developed fever of 102 degrees Fahrenheit. And in this fever, there was a further elevation of the ST segments, which again is seen in V1, V2. So we have a classic picture of an ST segment elevation with a T wave inversion, which is seen in Brugada syndrome or Brugada disease. Now, later on, once the fever had settled down, the ECG again was more or less normal. That ST segment elevation, which was seen earlier in the height of his fever, and which showed a classic Brugada picture, has now resolved, and the ST segment has settled. And with this ECG, nobody can suspect a Brugada disease or a Brugada syndrome. Now, the patient was, of course, kept under observation. The blood cultures were negative. The viral panel was also negative. However, he tested positive for COVID-19. Now, remember, this is May 2020. The man was kept in isolation. He had no further symptoms, nothing serious after this. And most importantly, he did not throw any ectopics. There was no arrhythmia. There were no ventricular ectopics, no non-sustained VT, nor any sustained VT. He, at that point of time, was not subjected to a programmed stimulation in the EP lab. And he was discharged with the advice that he get an ICD implanted later on in the near future. However, those were strange times. I suppose there was lockdown. People were not going here and there. So we don't know what happened to this patient after that. But what is important here is that we have a case report of a man who develops fever because of COVID-19. And at the height of his fever, there are changes on the ECG. There is unmasking of a Brugada-like picture on the ECG. And so therefore, this is a classic case of a man having Brugada, which is highlighted or aggravated or amplified with fever. Now, sorry. This, of course, can happen to anyone with fever. We in Delhi are very well aware, all physicians in India are well aware of the multiple factors causing fever. But we have a bunch of diseases, a handful of diseases which are almost or endemic in India. For instance, we have dengue. There can be fever because of dengue. There can be fever because of malaria. There can be fever because of typhoid. Chikungunya can cause fever. And of course, there is a respiratory virus or even influenza comes around in India. So therefore, the point to make here is that any fever can precipitate a Brugada-like situation. And what is Brugada? That is very important. Brugada was first reported in 1992. Some say that it was earlier described in 1989, but the first paper was published in the Journal of American College of Cardiology. And this was in 1992, November 15th. And this was a report by the Brugada brothers. And here they described 8 people with this strange ECG phenomenon of a right bundle branch block and persistent ST segment elevation and sudden cardiac death. Their ages range from 2 years to 53 years. 6 were males, 2 were females. And what is important to keep in mind here is that all these people had a normal QT interval, but this was the first description of what is called a Brugada syndrome. Here we find that in all these patients, we had the classic picture of a Brugada ECG. That is in V1 and V2. These are the various patients. The ECGs are provided. We find that there is an ST elevation of a coving kind. The T wave is inverted. This is a classic Brugada type 1 ECG change, and of course accompanied by a right bundle branch block. What is Brugada? That is very important to keep in mind. Brugada is a channelopathy. For the physicians who are watching this video, in Brugada, there is a mutation in a gene called the sodium channel 5A gene. Of course, other genes could be involved also, but this is the most common variety. It is seen largely in men. It manifests itself in young men. What happens is these men suddenly develop a ventricular tachycardia or ventricular fibrillation and sadly die. Apart from the ventricular arrhythmias, they can also have, in some people, they can have atrial fibrillation, silent node disease, but predominantly, the danger is that such young men, and even women, of course, can develop life-threatening ventricular arrhythmias and ventricular fibrillation. So this, of course, was a case report published in May 2020 of a man 49 years old who was admitted for a collapse at home. And when he had fever in the hospital, the ECG showed classic changes of the Brugada syndrome. Now, what is the mutation and what does it do? The mutation are many in this gene. There could be, some say 280 mutations, but largely, in fact, the mutations are of a loss of function of the sodium channels. What this means is either these people are born with fewer sodium channels, or if they have adequate sodium channels, the sodium channels are not working adequately. And this is what is happening. By and large, in fact, it was believed that these people had no structural heart disease, but now it is believed, there are reports that there is an involvement of the right ventricular outflow tract. There is the presence of some fibrosis and fatty infiltration. However, there are these people who have Brugada syndrome. The prevalence is there. It is not a very rare disease. It is uncommon, of course, and it is more prevalent in Southeast Asia. I have seen 2 patients in Delhi. One patient collapsed as he dropped his child to the school and had anoxic injury. And what else about Brugada syndrome? The treatment, of course, is if a person, now this is very important, if a person has Brugada syndrome, as per the ECG, and has a history of cardiac arrest or syncope, then the treatment is an implantation of a cardioverter defibrillator, that is an ICD. And even if the arrhythmia persists after implantation of the ICD, then of course there's a drug called quinidine which can be used. And in people who are not willing for an ICD, in them, quinidine can be used in these patients. So once again, this is a genetic condition. There is a mutation, multiple mutations. kinds of mutations in the sodium channel 5A gene. The result is that there are changes on the ECG, which are presenting as a right bundle branch block and ST segment elevation with a T wave inversion. There are two more changes on the ECG, but I will not describe them. They are uncommon. And rather they don't manifest as, they don't trigger ventricular tachycardias. However, if there is an insult to the human body, such as a fever or even an alcohol intake or a large meal, then these people can develop ventricular fibrillation. Apart from this, of course, this can also occur while the person is asleep or at rest. So therefore, if someone says that so-and-so died in his or her sleep, it is not necessarily a vaccine injury. It could have been a Brugada, or it could have been a long QT3 syndrome, which also manifests itself, which also produces a dangerous arrhythmia, a lethal arrhythmia during sleep. So what else do I tell you about Brugada? There's nothing much more to tell. You can, of course, read it up yourself. But what I am trying to explain to you is that if a person dies suddenly after having fever or while asleep, it is not and cannot always be a result of a vaccine adverse effect. It could be a Brugada, it could be a long QT3 syndrome, it could be an obstructive sleep apnea, it could be a heart attack or whatever. But certainly the point I'm making again and again is that every death cannot be attributed to a vaccine adverse effect. Now, the second report, which I will talk about, is a Tossard de Pontis following vaccination for COVID-19. This has been published last year in June, once again in the Heart Rhythm Case Reports. This describes a 65-year-old woman who, about a month after her second Pfizer vaccine shot, or a messenger RNA vaccine shot, became unconscious for about a minute or two. This woman was brought to the hospital. This was her ECG. We see that the person has a left bundle branch block. The age of the woman is 65 years. She's had no previous history of syncope. And we have a left bundle branch block on the ECG. We have some atrial ectopics and some ventricular ectopics. This woman has a history of hypertension also. An angiogram was done, and the angiogram was not done at this point. However, an echo was done at this point, which showed ventricular dysynchrony, which is understandable because of the left bundle branch block. And the ejection fraction was about 45 to 50%. And this woman underwent an EP study. She had programmed extra stimulation done with 3 premature beats. No ventricular arrhythmia could be elicited. She was provided with an implantable loop recorder, which could record her beats for the next few weeks. And following this, she had her booster dose 5 months after the second shot. So 5 months after her second messenger RNA vaccine, this woman got her booster shot. And soon after her booster shot, 12 hours after her booster shot, while she was watching television in her house, this woman collapsed. Luckily, her husband was there, who immediately began a heart massage, called up the ambulance, the paramedics came. Now, what is important is, while you're looking at this ECG, this has been done some months prior, 5 months prior to the cardiac arrest at her house. Apart from the left bundle branch block, what is very important is that the QT interval, the corrected QT interval here, is about 517 milliseconds, which is more than the threshold. That is, all societies which have published guidelines on the long QT syndrome strongly recommend that a person who has had a cardiac arrest or who has a QT which is longer than 500 milliseconds is a candidate for an ICD, or definitely some form of treatment. Now we come back to this woman. So after her initial collapse, which lasted just a couple of minutes, and her programmed stimulation, which was unremarkable. It did not induce any arrhythmia. 5 months after that, she has a booster, and 12 hours after her booster, this woman faints in her house. You have a CPR initiated by her husband. The paramedics arrive, and remember, she already has a loop recorder inside her. And the loop recorder then reveals that this woman was having occasional ventricular ectopics, and a ventricular ectopic triggered a torsade de Pontus, that is a polymorphic ventricular tachycardia, which then degenerated into ventricular fibrillation. Now, the paramedics at her house during cardiac resuscitation, of course, had a defibrillator and figured out by the defibrillator that she was having ventricular fibrillation and gave her a shock. She, in fact, needed 12 to 14 shocks for resuscitation. She was brought to the hospital. She underwent an angiogram, a coronary angiogram, which showed that the arteries were normal. And during this cardiac resuscitation effort, because so many times she had ventricular fibrillation because of a very high burden of ventricular fibrillation, she also received intravenous amiodarone. And following the episode, we have this agonal rhythm, and which we are all familiar with. And of course, once she sort of normalized to some extent, we find that the QT interval is still quite prolonged. Remember, her coronary angiogram was done, the coronary arteries were normal. The echo done previously had an ejection fraction of 45 to 50%. And the first ECG done 5 months back had a corrected QT more than 500 milliseconds, in fact, of a corrected QT of 517 milliseconds. And this time, after her cardiac arrest, when she has been shocked 12 to, I think, 14 times, we have a QT interval, a corrected QT, which exceeds 600 milliseconds, right? This is very important. Now, the case report is saying that this person has had a torsade de Pontus because of her vaccination. But of course, no cardiac MRI was done, no PET scan was done, and this woman had no genetic testing. Now, I am very familiar, I won't call myself an expert, but I am slightly abreast with the long QT syndrome because a case report of mine has been published in the current issue of the Indian Heart Journal case reports. And I am aware, and this is linked in my paper. I have linked the guidelines supplied by the European Society of Cardiology last year. And we are also aware, because of the international registry on long QT syndrome, that there can be a situation wherein a person can have 200 episodes of cardiac arrest. Yes, I repeat, 200 episodes of syncope, not cardiac arrest, 200 episodes of syncope, and yet be asymptomatic at the age of 45 or 50 years. The reverse is also true. There could be a person who is entirely asymptomatic while young, during the teenage years, as a young person, and then suddenly die. And if you do an autopsy genetic testing, you will find that the person is having a prolonged QT syndrome. So what I would like to, I will take the liberty and the audacity to question this case report, which has been published in Heart Rhythm, which is saying that the person had a torsade de Pontus, that is a polymorphic ventricular tachycardia, which was life-threatening, which could have killed her, because of the COVID vaccine. I disagree, because as I've said, they could not prove any myocarditis. They did not do any PET scan. And to say that the vaccine is causing a prolongation of QT is pretty far-fetched, because anyway, the prevalence of the long QT syndrome is as high as 1 per 2,000, that means it is quite prevalent. 1 per 2,000 is quite prevalent. Some, of course, are congenital. Most of them are acquired because of drugs, because of hyperkalemia, because of certain situations. And therefore, before we emphatically state that a person had a Torsades de Pointes because of a vaccine, we must be aware that there is a very strong possibility, in fact, a very strong probability that the person concerned actually had a long QT syndrome to begin with and was asymptomatic before this incident took place. And the chances of that person having a concealed long QT are much higher, and eventually, ultimately, the long QT syndrome triggered the life-threatening ventricular tachycardia. Now, this is very important. Now, what else do I say? Because I have described these two cases at the beginning of this video. I have emphasized that all over the world we are seeing excess deaths. The actuaries are reporting it. The actuaries are incapable of giving us a reason, or maybe they are too timid. We know that there is a strong chance that there is vaccine injury which can be attributed for these excess deaths. But every excess death, we cannot be so melodramatic and say that every death which is occurring in the community is because of vaccines. There can be other causes also. We are very aware. Even in athletics, even in the sporting field, before the COVID pandemic, the commonest cause was hypertrophic cardiomyopathy for a sudden death, for a collapse. There are other reasons also. You could have a right ventricular cardiomyopathy. You could have coronary artery anomalies. You can have channelopathies like I've described just now, long QT and Brugada. So remember, people are dying. Of course, people die every day. Sadly, in our country, I had researched this earlier. On a single day before the pandemic began, almost 22 to 24,000 people died on a single day in India. So deaths are not uncommon. Many people die, but because of the pandemic, there is more focus on these deaths. But I will repeat again, ad nauseum, that every death which is occurring cannot be ascribed to the COVID vaccine. Thank you very much.